All right, good morning. My name is Ruchir Puri. I'm a general surgeon at University of Florida in Jacksonville, and it is my honor today to interview Dr. C. Dan Smith, one of my mentors and guru. I asked Dr. Smith yesterday how would he like to be introduced, and all he said is that you need to say, I love to operate, which is very true for him. He's done so much that it's impossible to summarize all his accomplishments, but in brief, he went to medical school at University of Minnesota, followed by a general surgery residency at Mayo Clinic in Rochester, and a minimally invasive surgery fellowship at St. Louis and Montreal. His first job was at University of Cincinnati, where he was the director of minimally invasive surgery. Subsequently, he moved to Emory in 1996, and during this time, he pioneered, amongst others, the laparoscopic Nissen fundoplication. His work here led to better understanding of gastroesophageal reflux disease and operative and reoperative anti-reflux surgery. He was then appointed the chair of general surgery at Mayo Clinic in Florida in 2007, where I was fortunate enough to be one of his fellows. He has since moved back to Atlanta, and he's doing what he loves to do the most, that is operate. He is indeed a lifelong innovator. He's a master surgeon, he's a trailblazer, and undoubtedly one of the pioneers of Foregut Surgery. And today it's an honor to interview him. Dr. Smith, thank you for your time.
For sure, thanks for doing this. I am honored to be recognized in this way, especially by you, a past fellow. So it means a lot to me. And I would only say that my answer to your question, how to introduce me, I think I said that I'm still operating.
Still operating.
I do love to operate, but still operating.
Yes.
And I think as someone at my point in my career, that's important. I think that's how we start our careers. We get involved in academics, we get involved in innovation and research, but we're surgeons, and I'm still operating. I'm proud of that.
Dr. Smith, my first question is, how did you get involved with Foregut Surgery?
Well, as you know, I finished my training in the early 90s when laparoscopy was just emerging. And I went to Montreal and spent some time with Michel Gagne, and really got interested in in solid organ at that time. 3 years in Cincinnati, focusing more on solid organ. Then I had a chance to go to Emory, and as you know, John Hunter was at Emory, and John really is one of the grandfathers and pioneers in Foregut. And it was that association with John that then really got me going in the Foregut space. John and I, as partners, took care of a lot of patients with GERD and other esophageal conditions, so that really launched me into Foregut.
And so, in terms of Foregut surgery and anti-reflux surgery, what do you think is the most important part of workup for a patient with reflux?
Well, I think today it's the objective diagnosis of reflux. I continue to see patients who've had surgical care for GERD who didn't have a pH test and didn't have objective evidence on endoscopy of reflux. I think you really need to be certain of that diagnosis, and it's made with objective data as opposed to just a clinical presentation of heartburn that responds to a PPI.
And in terms of the actual creation of the wrap, and I know you emphasized a lot how to properly construct the wrap when I was a fellow. Could you just shed some light on what you think is the most key technical aspect of the wrap creation?
Well, I think the most common thing I see where maybe that isn't done the way it should be or would best be done is failure to take down all the short gastrics and do a complete hiatal mobilization and fundic mobilization. Without that, you're prone to either result with a twisted wrap because you've left a high posterior short gastric, or the wrap will be low and won't be around the esophagus, but instead will be around the top of the stomach, around the gastrocardia.
Right. Do you do partial fundoplications? I know you do it rarely. Yeah. When do you do them?
Yeah, I feel like this is a setup. Because I think there are two answers that I would offer. I think the use of a partial fundoplication is important for patients that have compromised esophageal motility. And typically that's defined as a body pressure of less than 30 or 35 millimeters of mercury and less than 70% peristalsis. Now that said, in my practice, I rarely will use a partial fundoplication because those patients typically are the ones that have the worst reflux. And the partial fundoplication will, over time, have a much higher rate of failure of reflux control. So I think a well-done, loose, floppy Nissen is as good as a partial fundal plication in most cases. So I don't use it that often.
Okay. And I know, I saw this a lot, and I know you still do it, and that's reoperative foregut surgery. And without a doubt, I think you need to be at a certain level of comfort with primary initial operation before you can actually do reoperative surgery. What is the cutoff? What's the threshold where you take that next step and you think people would feel more comfortable? I know it's different for every person.
Yeah, so if I understand your question, it's when would or should someone venture into reoperative foregut surgery? And it's a difficult answer. I will say there's data in the literature that would indicate that you need to be doing 20 to 25 wraps or foregut procedures a year to have achieved a level of proficiency in being able to do it well and safely. So you could use that as a threshold. But you know, one of the keys to redo surgery is pattern recognition. You've watched me as we did redos. Understand where to go with your first dissection plane to find that safely. You don't necessarily have to do a lot of foregut surgery to get skilled at that, but you just have to be patient and comfortable with the tedium it takes sometimes to do that pattern recognition and find those tissue planes correctly. When I see people struggle with reoperative surgery, it's when they've overbooked themselves into the operating room. They've got 3 more cases to do and they feel a certain pressure
To be quick.
And you really have to just meticulously go tissue plane by tissue plane until you can expose all of it. And at the end of the day, and you've heard me say this repeatedly, they all look alike when you get all finished. When you get it all taken apart, what looks like a total mess, they all wind up looking exactly the same.
So it's so funny, I say that to residents now. Like, in the end, it always looks the same. The wrap looks the same.
Everything should look the same, but you have to take a bunch of different paths sometimes to get that to that point. And in reoperative surgery, it's really being patient with that.
Right. Along those lines, so what do you think is the most common cause of hiatal hernia recurrence?
I think it's failure to do a complete hiatal dissection and to mobilize high up into the mediastinum. I know, and I'll stay away from this topic because it would occupy this entire discussion, the whole mesh to avoid recurrence and to improve outcomes in hiatal hernia. Rarely do I find, if I do a complete hiatal dissection, mobilize that esophagus and that stomach out of the mediastinum, rarely do I find that I can't get a good tension-free closure posteriorly and get a good outcome. The second thing is I have started using more anterior sutures also. As you bring that posterior space closed, sometimes you just can't get that last stitch in to get it approximated, but you can push the esophagus down into that and put an anterior stitch very well. So I think these are key intraoperative characteristics I think help substantially.
Now, one of the things you taught me, and I think you taught all your fellows, is in a reoperative situation, always take down the initial wrap.
Yes.
Just comment about that if you could.
Well, it's 2 comments. First off, you don't know what was done. Oftentimes these redos are not your own, hopefully. Not a lot of them are your own.
Hopefully not.
And so I'm uncomfortable relying on any imaging or any preoperative workup to tell me that wrap is in its right location and that there's not something fundamentally wrong with the wrap. So I feel strongly you have to take it all apart and again, get it to where it looks the same at the end of that dissection in every single case, and that means take down that wrap. Quick story, gosh, 3 weeks ago I did a redo, read the last operative note, went into the operating room, took the wrap apart, and my scrub tech said, Dr. Smith, why do you always take these apart? And in the middle of that discussion, as I took that wrap down, there was another wrap. The prior surgeon who did, this is the 3rd redo, the surgeon who did the 2nd redo failed to take down the first wrap and just wrapped another wrap around the first wrap. So it was an opportunity for me to say, see, this is why I always take it down, because you're never quite sure what's going to be under there until you get it all apart.
Now, I know you do a lot of reoperative surgery, and one of the topics that comes up frequently is the so-called short esophagus. And I think your belief is that it exists, but maybe not to the extent that we think it exists. Or is that accurate?
Yeah, no, you're absolutely right. And we've written about this, the endoscopic evidence or radiographic evidence of a short esophagus will put that rate at somewhere between 10 and 15%. But if you do a full hiatal dissection, it's going to be 2% or less of the time that you'll find a short esophagus. And even in those situations, I'm not a big fan of the collis gastroplasty. It's a tricky operation to get right, and I think surgeons who use that are at risk for extending that staple line too far and trying to get too much length. And then you get a wrap around proximal stomach and you leave a little bit of stomach above that wrap, and now you have an obstructed outlet essentially. You've got a little cardia above a wrap that's obstructing its outlet. And we did at Emory, I think we published this, we looked at our collis patients, and unfortunately too many of them had recurrent esophagitis or Barrett's develop, and it was because those wraps get too low. So it's pretty infrequent that I will feel the need to do a collis. And often, the last thing I'll say about this is oftentimes when that short esophagus exists, the proximal stomach has essentially been tubularized by the chronicity of the existence of the hiatal hernia and the hiatal kind of pinch in the short esophagus. You don't have to put a staple line on that to get that extra 2 or 3 centimeters. You already have it tubularized, and you can put that wrap just a little bit low and extend its length that way. So,
yes. One thing that I remember clearly that you emphasized during our time is an accurate history and a thorough history prior to any primary or reoperative foregut procedure. If you could just comment on that.
well, and reflecting back on my earlier comment about the patient where I found a wrap in a wrap, it's always good to know as best you can what you're getting into, so you can prepare, whether it's the operative time, special instruments. If you think you're going to have a short esophagus, I don't have staples in my room all the time.
Right.
If I suspect a short esophagus based on presentation history, I can be better prepared. So I do think it's important. Try to get the prior operative reports if you can. Get your data lined up. And really, the other thing I will tell you is I'm spending more and more time talking to patients and hearing about their symptoms. Because I'm finding that's very helpful in anticipating what I'm going to find and how I can best help them.
Lastly, Dr. Smith, in the last 30 years, what do you think has been the most significant advancement in the field of esophageal reflux and gastroesophageal reflux disease?
Well, since you gave me 30 years to work with, I will say that 30 years ago, a huge advancement was introduction of proton pump inhibitors and wider availability of objective diagnostics, flexible endoscopy being more widely available, and 24-hour pH monitoring. That was 30 years ago. Now, if you gave me a shorter segment of time, I would say I'm a little bit embarrassed that during that 30-year span, we have not had exponential improvements come along. And up until more recently, basically all we had was PPIs and a Nissen fundal plication. Now, and full disclosure, I work very closely with the company that developed the device called Lynx. I worked with them eagerly because their data was so strong. And so I think Lynx has been a substantial addition to what we have today. And it's reinvigorated a lot of interest in reflux because doctors, surgeons, and gastroenterologists alike aren't that excited when you only have 2 offerings and you don't feel that there are very many patients who really can justifiably be cared for within those ends of that spectrum.
Right.
So Lynx is going to help us find patients who don't need a Nissen, but PPIs are unsatisfactory. And there's a whole host of other interventions now coming along. And this is how I spend my time, more of my time now, rather than in typical academics and in administration, I spend more of my time now working with these startup companies
Right.
to help develop additional tools now in GERD. Long answer, I'm sorry, but
No, but I lied. I have one more question because of what you just said.
okay.
So who's that patient? What is that patient profile who would be better for LINX and not Nissen?
Well, you know, the downside to fundoplication, and if we talk about fundoplication objectively, the utilization of fundoplication for the treatment of reflux has been flat and decreasing
Right.
over the years. And you could ask the question why. It does take some skill and experience, and ongoing experience, to get a good outcome with a fundoplication. And unfortunately, a lot of surgeons weren't doing enough Nissens every year to maintain that skill level. So we saw quality of outcomes start to drop. At the same time, the side effects of Nissens, even in my hands, sometimes can be challenging for patients. We know that gas bloat can be an issue. And when we looked at it, we sort of said the Nissen and the current 360-degree fundoplication is almost supraphysiologic. It's too good.
It's too good.
Not only is it preventing acid reflux, but it's preventing normal, natural physiologic function, and in particular belching and vomiting.
Right.
And that scared a lot of patients away from that operation, and it scared a lot of gastroenterologists away because they refer the patient for surgery. Surgeon does the operation, patient comes back and says, I'm bloated. Surgeon says, go see your gastroenterologist.
Right.
And the GI says, well, what did I do?
Right.
You know, I just traded problems.
Right.
So LINX is really ideally suited to the patient who has not full-blown reflux with active Barrett's or esophagitis, but rather the patient who's on the continuum of the failed sphincter. LINX augments the sphincter.
Right.
If we wait till the sphincter is completely gone, Nissen's probably better. But if we can find these patients a little earlier in that process, in fact, I think it's the PPI failure who's regurgitating, who still has some sphincter function. We don't need the supraphysiologic effect of the Nissen in that case.
Right.
The LINX is a much more physiologic option. Patients can more naturally belch and vomit. And we don't alter the gastric anatomy. Redoing a LINX situation just means remove the device and progress to Nissen.
Right.
So it's moving the severity of the disease and the treatment down the continuum a little bit. So
And I think that makes a lot of sense, where more severe reflux, complicated reflux, can get a Nissen, but maybe between PPIs and Nissen, there's a space for LINX.
yeah, you know, I'm really proud of the work I've done in this space, and again, I appreciate the opportunity to visit with you about this. But as a foregut surgeon and an esophageal expert and specialist, I'm a little bit embarrassed, and in times even ashamed that space between PPI and Nissen is a huge space.
Huge lacuna.
And we haven't effectively segmented within that space and found less invasive but more effective therapies in that 30-year span. And so back to your question, I think LINX has issues like anything we do, but it is the most compelling thing that's come along during my time, and it's reinvigorating the interest in this disease and clinicians' interest in looking for other things that can fill in that gap. And I think that's really exciting.
Well, Dr. Smith, thank you so much for your time.
Yeah, thank
It's a
you.
pleasure and honor
Thank you.
to be interviewing you as the trailblazer of Foregut Surgery for
Yeah.
SAGES.
Thanks.
you.
Appreciate it.